So, seborrheic dermatitis is a common, chronic papulo-squamous disorder affecting infants and adults alike. It is characteristically found in regions of the body with high concentration of sebaceous follicles and active sebaceous glands, including the face, scalp, ears, upper trunk, and flexures like inguinal, inframammary, and axillary. Less commonly involved sites include interscapular, umbilical, perineum, and the anogenital crease. Seborrheic dermatitis affects two main age groups: infants, mostly in the first 3 months, and adults. It is more common in males at all ages and doesn't depend on race or spread from person to person. About 3 to 5% of young adults and 1 to 5% of general population have it, but many more people may get it at some point in their lives. The exact cause of seborrheic dermatitis is not fully understood, but is often linked to the yeast Malassezia, immunologic abnormalities, sebaceous activity, and patient suspensibility. The amount of oil produced is not a crucial factor, since not all patients with seborrheic dermatitis have high oil levels. Similarly, some patients with high oil levels might not have seborrheic dermatitis. Patients with seborrheic dermatitis have high skin surface lipid levels like triglycerides and cholesterol, but lower levels of free fatty acids and squalane. Both Malassezia species and the resident flora Propionibacterium acnes break down triglycerides into free fatty acids. All 7 species of Malassezia are lipophilic, except the zoophilic species, Malassezia pachydermis. The free fatty acids and reactive oxygen produced have antibacterial effects that change the normal skin flora. Seasonal fluctuation in humidity and temperature can worsen this disease, especially with low humidity and cold temperature in winter and early spring, with some relief in the summer. Facial prothylene plus ultraviolet radiation treatments and facial trauma, for example scratching, are also reported to trigger seborrheic dermatitis. The pathogenesis of seborrheic dermatitis has been debated since it was first described over 100 years ago. An imbalance of microbial flora likely plays a role in this disease. Also, some patients may have cultures showing Candida albicans, Staphylococcus aureus, and Propionibacterium acnes, and other aerobic bacteria not have been linked to seborrheic dermatitis. Infants commonly experience secondary contamination and infections with Candida species. The number of yeast on the skin does not directly correlate with the severity of seborrheic dermatitis. Patients with both dandruff and seborrheic dermatitis generally have high yeast count compared to controls, supporting the role of yeast in this disease. A higher rate of seborrheic dermatitis is also seen in patients with Piturosporum folliculitis and Tinea vesicolor. The clearance of seborrheic dermatitis with antifungals and its recurrence after stopping therapy also support the idea that Malassezia species is pathogenic. Several drugs are known to trigger seborrheic dermatitis like eruptions. You can see the full list in the table. In all patients with seborrheic dermatitis, there is so-called seborrheic stage, which is often combined with a gray-white or yellow-red skin discoloration, prominent follicular openings, and mild to severe pituriosiform scales. The clinical patterns in seborrheic dermatitis are different in children and adults. In children, it is usually scalp or cradle cap, trunk, like flexures and napkin area, and linear disease. In adults, it's usually scalp, face, eyelids, and trunk. In prognosis and clinical course, seborrheic dermatitis is self-limited with a good prognosis in infants, compared to being chronic and relapsing in adults. There is no evidence to suggest that infants with seborrheic dermatitis will have the disease as adults. Seborrheic dermatitis is a common skin condition that affects both infants and adults, but is present differently in each age group. Infantile seborrheic dermatitis typically occurs within the first few weeks to 3 months of life. It is a self-limited condition that usually resolves on its own as the baby grows. This timing coincides with a period when infants produce sebum or skin oil, which later decreases until puberty. The most common manifestation is cradle cap, where yellow-brown greasy scales form on the scalp. Those can sometimes spread across the entire scalp, causing redness, inflammation, and crusting. Lesion may also appear on the face, neck, and other parts of the body, including the trunk and extremities. In infants with widespread seborrheic dermatitis, it is important to consider other conditions like atopic dermatitis, which tends to affect different areas, for example forearms and shins, while sparing the axilla. Other conditions to consider include scabies, inflatable psoriasis, and Langerhans cell histiocytosis, which may require further testing or biopsies for accurate diagnosis. In adults, seborrheic dermatitis is usually a chronic condition that can persist for decades, with symptoms often peaking during middle age. Adults typically experience symptoms on the face, particularly in symmetrical patterns around the eyebrows, forehead, nasolabial fold, and behind the ears. The scalp, neck, and upper chest are also commonly affected, often with the fine pink scales. Erythema, itching, and burning sensation are frequent complaints. The adult form of seborrheic dermatitis often begins at puberty, linked to increased androgen activity which stimulates sebaceous glands. Unlike infants, adults may also experience associated conditions like pityriaziform folliculitis, particularly in immunocompromised individuals. Seborrheic dermatitis is an easy condition to diagnose because of its appearance on the affected skin and where it appears on the body. No blood, urine, or allergy tests are needed. Your dermatologist may perform a skin biopsy to rule out other diseases if your condition does not respond to treatment. Seborrheic dermatitis demonstrating parakeratosis in the epidermis, plugged follicular ostia, and spongiosis. AIDS-associated seborrheic dermatitis more commonly present as parakeratosis, a few individually necrotic keratinocytes within the epidermis, and plasma cells in the dermis. Yeast cells sometimes are visible within keratinocytes on special stains. If hyphae are present, dermatomycosis is the diagnosis. Shorter hyphae with spores, like spaghetti and meatball pattern, are present with tinea versicolor. Treatment of infantile seborrheic dermatitis. This harmless condition goes away on its own, and it's easily treated with shampoos, emollients, and mild topical steroids. Babies with long-lasting inflammation on the scalp or skin folds can use low-potency topical corticosteroids like hydrocortisone 1% cream or lotion for a few days. Then use creams with ketoconazole 2% cream, lotion, or 1% shampoo. Do not scrape off the scales aggressively to avoid more inflammation. However, mild baby shampoos, sometimes with 3% salicylic acid, can help remove thick scales on the scalp. If there are secondary inflammation with candidas or staphylococcus, they should be treated properly. Changes in diet or adding vitamins do not help babies with seborrheic dermatitis. Adults often have a chronic and recurring condition. The goal of treatment is to control, not to cure the disease. Scalp seborrheic dermatitis can be treated with shampoos with zinc propion, selenium sulfate 1 to 2.5%, imidazoles like ketoconazole 1 to 2%, cyclopirox, cream gel or shampoo, coal tar, cream shampoos, or mild detergents. Dandruff involves the face and scalp with extensive scale, but minimal inflammation. It responds to more frequent shampooing or longer lathering. Shampoos can be used on the scalp, beard, and chest, but may flare the disease if used on the face or other intergenous areas if left on the extended periods. Severe scales on the scalp can respond to overnight application of topical corticosteroids, low, mild or high potency creams, lotions or foams, depending on the severity, with shower cap occlusion as needed, Baker's P&S solution, tar shampoo or salicylic acid, ointment or shampoo, especially for patients with pityriasis or Malassezia. Patients should avoid aggressive manipulation. Hairsprays and hair pomades should be stopped. Treatment of any underlying secondary microbial infection should be treated as well. Patients with severe inflammatory disease that fail the above regimens may respond to a 1-week course of systemic glucocorticosteroids like prednisolone or 0.5 mg by kilogram body weight by day, while cautioning the patients of side effects and informing them of potential rebound flares following discontinuation of medication. Treatment of the face, trunk and ears includes short courses of low-potency topical glucocorticosteroids, class 4 or lower, to suppress the initial inflammation. Excessive and long-term use of topical corticosteroids should be avoided to prevent skin issues like steroid acne and rosacea. Instead, use topical calcineurin inhibitors like pimecrolimus and tacrolimus, which reduce inflammation and have fewer side effects. Topical antifungals like ketoconazole, miconazole and fluconazole can also be used with varying success. Other treatments include sulfur or sulfamide combinations, propylene glycol and benzoyl peroxide wash 5 to 10%. Patients should avoid alcohol-based solution that can worsen the condition. For seborrheic otitis externa, aluminium acetate solution can be used. Patients with seborrheic blepharitis can use warm compresses and baby shampoo for cleaning, followed by gentle removal of thick scales with cotton tip. Avoid using ocular glucocorticosteroids. If seborrheic blepharitis is resistant, ophthalmic sodium sulfacetamide ointment can be used. Also, there are several myths and misconceptions surrounding seborrheic dermatitis. Dispelling those myths can help patients better understand and manage their condition. The first myth is that seborrheic dermatitis is contagious. In fact, seborrheic dermatitis is not contagious. It cannot be spread from person to person through contact. It is a chronic skin condition influenced by factors like genetics, yeast overgrowth, and immune response, but it is not infectious. Second myth is that poor hygiene causes seborrheic dermatitis. While maintaining good hygiene is important, poor hygiene is not a cause of seborrheic dermatitis. The condition is related to factors like skin oil production, the presence of Malassezia yeast, and individual susceptibility rather than cleanliness. Third myth is that seborrheic dermatitis is the same as a dandruff. While seborrheic dermatitis and dandruff share some similarities, they are not the same. Dandruff is a milder form of seborrheic dermatitis that primarily affects the scalp, whereas seborrheic dermatitis can also involve other oily areas of the body and often includes more inflammation. And the last myth is that seborrheic dermatitis can be cured permanently. Seborrheic dermatitis is a chronic condition with periods of remission and flares up. While it can be managed effectively with treatment, it is not curable and symptoms can recur.